Morning class. So today we will be talking about basics of CT scan and MRI of the brain. Okay, so this will be our last topic for your neuroscience class this year. So let's start. Basic principles. So first we will talk about CT scan. Okay, CT scan or computed tomography scan. Computed tomography. It was discovered by Sir Godfrey Hounsfield in 1972. And these are the basic parts of the CT scan. So you have the gantry, which houses the X-ray apparatus. The X-ray tube, you have the detectors for the X-ray. Of course, the patient couch, where you put the patient, and the viewing console or the computer, where you view the images. So basically, the CT scan is a series of X-rays sequentially applied to the structures of the body, and the images are reconstructed from the X-ray absorption data, and it is reconstructed computationally. So that's what it's a computed tomography scan. So basically, X-rays are passed through the body, a series of X-rays. All those data are gathered by the computer. It computes the volumetric coefficient of the different areas of the body, and thus it forms the image on the CT scan. So here's how it looks like. So we have here, we have the X-rays, basically series of X-rays sequentially slices the body. So it's basically like slicing a ham, no, or slicing a piece of meat using a series of X-rays and then reconstructing all those images that you see. So it provides a 3D display of the intracranial anatomy built up from a vertical series of transverse axial tomograms. A vertical series of transverse or axial tomograms. So basically, X-rays are passed through the skull transversely, axial cuts, and then it's reconstructed vertically. Okay? Each tomogram represents a horizontal slice through the patient's head. So this is usually how it is done. Basic interpretation, so always describe CT findings as densities. So it's either isodense, hypodense, or hyperdense. What is the reference density? How do you say it? Is isodense, hypodense, or hyperdense? Okay, always the reference density is the brain. The brain is the reference density. Anything whiter in appearance than the brain is higher density, meaning hyperdense. Okay, and anything lower in appearance than the brain is considered hypodense. Okay? Higher density than the brain usually is the skull. Of course, the skull is made up of bone, and thus it has a lot of calcium, and it absorbs the X-rays and does not let it pass through. Anything darker, okay, than the brain, hypodense, CSF and air are classic examples of these. Okay, CSF, largely made up of water, not a lot of, doesn't have soft tissue. Of course, air is black on CT. So these are hypodense to the brain. The brain and the surrounding structures are, of course, the reference density. And then you have the skull, which is hyperdense, more dense, whiter in appearance than the brain on CT scan. And of course, CSF and air are darker in appearance or hypodense to the brain. Okay? So, the density is related to the composition and nature of the tissue and represent the density, also called as a CT number. So this is a simple table showing you the Hounsfield units. Okay, so pure water is 0, air and fat less than 0. Of course, as you move towards bone, you get more CT number or Hounsfield numbers. Okay, so this is a simple illustration. Here you have CSF, this is probably the ventricle, this is brain matter, okay? And this is bone, and this is air. Of course, surrounding the skull is air, okay? This is not the inside of the skull, unless you're an airhead. So, brain matter, this is the reference density. It's gray, as you can see. Each pixel is represented by how much X-ray passed through or absorbed. Of course, bone is hyperdense to brain. It is lighter in appearance. It appears more white. And of course, CSF, as you can see here, and air are hypodense to the brain. They are darker in appearance. Okay, so this is an example of the axial cuts and some structures that are important to know. Okay, so usually the lowest cut is about the level of the foramen magnum at the skull base, traversing the floor of the anterior cranial fossa, housing the frontal lobe. So here you have the orbit. Okay, you have the sphenoid sinus here. This is the central sphenoid sinus. You have the temporal lobes. Okay, of course, the external auditory canal, the mastoid air cells you have here, and of course the cerebellar hemispheres. Okay, so remember the structures. You have the orbits, sphenoid sinus, temporal lobe, you have the ear, external auditory canal, the mastoid air cells here, and the cerebellar hemispheres. So usually, when you order a cranial CT scan, most centers would use 5 to 10 millimeter cuts. For us, when we do ear surgeries, we usually request for a temporal bone CT, and usually they are closer together. The cuts are closer together, so it's usually 1 to 2 millimeter cuts. But for a regular cranial CT, usually it's around 5 millimeter cuts. So this one, just above the foramen magnum, about the level of the base of the frontal lobe, above the anterior cranial fossa, you have the frontal lobe, of course, the dorsum sellae, or that where the pituitary gland is found. You have the basilar artery right here. You can see this. This is a blood vessel, the basilar artery. Remember, the basilar artery is formed from the 2 vertebral arteries around the lower surface of the pons. They join together to become the basilar artery. Okay, so then you have some of the mastoid air cells, of course, the temporal lobe here, and more superior, the cerebellar hemispheres. Okay, for this cut, this is around the level of the midbrain, above the pons. You have the frontal lobe, the suprasellar cistern here. Remember the cisterns where the subarachnoid space are larger. The arachnoid matter does not closely follow the brain. They're called cisterns. Okay, so you have the sylvian fissure right here. And of course, the fourth ventricle is around this area. So here's the fourth ventricle. Around this area. Okay. So further up. Okay. So further up, so you have the anterior horn of the lateral ventricle. Here, you can see this anterior horn of the lateral ventricle. You have the falx cerebri. So if you can remember the falx cerebri, this is a fold of dura mater where the endosteal and meningeal layer are not attached. They form dural partitions. They invaginate into the falx cerebri invaginates into the longitudinal fissure of the brain, and within it is contained the dural venous sinuses, the superior sagittal sinus. Okay, further up, these are the structures to be noted. Okay, importantly, now you have the occipital lobe in the cut. Earlier, you don't have the occipital lobe, it's only at the level of the cerebellum. Now, you have the occipital lobe here. Okay, the third ventricle here, slit-like. Okay, further up. Okay, so you can read Radiopedia, very helpful to read CT, head, and approach. So please copy the link. So of course, all of those are in soft tissue density. Remember that In CT scan, usually you have what you call windowing and leveling. So windowing, usually you have two windows. You have the soft tissue window, and of course you have bone window. These are the two basic windows, okay? You have other windows, like for example, you have some they call it subdural window and stuff like that. But the most basic is soft tissue window and of course bone window. The views right here shown are mostly soft tissue window. If you can see, the bone is not clearly defined, right? It's all white, it's very white, it's not clearly defined. Whereas the soft tissue, the brain, you can see some detail in the brain. Okay, so you can clearly see some structures are more white and some structures are more gray or darker. And this is characteristic of a soft tissue window. If it's a bone window, you will see mostly the brain is very fine gray and you will see more detail in the bone. You can even delineate the two tables of the skull bones, the outer and inner table, and of course, in them, the diploic bone, the diploe. Okay, so now let's move on to MRI. MRI, the basics of an MRI. Of course, this is how it works. The patient is placed inside a magnetic field, then radio frequencies are sent in, the radio frequency is turned off, the patient emits a signal, and the magnetic field, you have receivers in the magnetic field, they receive the patient signals, and they use this to reconstruct a picture. So it's basically, the patient is put in a magnetic field, radio frequencies are sent in. Once the radio frequencies are turned off, the patient emits a signal back. These are captured by the receivers, and it is reconstructed in a picture. So it is based on the principle of nuclear magnetic resonance. Of course, atoms with an odd number of protons or neutrons, they spin because they're not balanced. So a moving electric charge produces a magnetic field, and the body has such atoms that can act as good nuclear magnetic resonance. So hydrogen is the atom that is used in the body. Each hydrogen nucleus is a tiny magnet which produces small but noticeable magnetic field. Oh, sorry. Small magnetic field. So this is the one that is read by the receiver on the MRI. Hydrogen is abundant in the body in the form of water and fat, of course. Fat is hydrocarbon. So it has a lot of hydrogen. And of course, water. Essentially, all MRI is hydrogen imaging. Okay, in our natural state, hydrogen ions in the body are spinning in a haphazard fashion and cancel all the magnetism. Of course, when an external magnetic field is applied, protons in the body align in one direction. Okay, so normally, the protons in our body, the hydrogen atoms in our body, they spin in a haphazard fashion, and this produces cancelling out of all magnetism. Obviously, we don't magnet metal. But during an MRI, when the radio frequency pulse is sent, an external magnetic field is applied to all those hydrogen atoms in our body, to all the protons in the specific area, and they all align in one direction. So, moving away from the haphazard motion, they align in one direction. Okay, so in MRI, you have two basic spin. Okay, you have T1 and T2. So T1 and T2. So how do we define T1 and T2? T1, of course, white matter is brighter than gray matter. Okay, so how do you remember this? T1 produces a better image of fat. T1 produces a better image of fat. More detailed image of fat. Okay? So, these are the following structures that are dark on T1. So you have CSF, which is water, edema, water, inflammation. Of course, you have edema and inflammation, so it has more water, so it is dark on T1. hemorrhage, low proton density and calcification. Of course, bright on T1, fat, subacute hemorrhage, melanin, protein-rich fluid, slowly flowing blood, and paramagnetic substances. Of course, like I said earlier, T1 produces a better image of fat. And on T2, the reverse is true, or the opposite is true. So gray matter, brighter than white matter. Remember, white matter, it has a lot of fat. The neural sheet has a lot of fat. So that's why it is brighter on T1 than on T2, whereas gray matter is mostly neurons. So on T2, CSF, edema, infection, inflammation, all of these are brighter. And of course, darker on T2, fibrous tissue, methemoglobin, and the like. So this is an example of a difference between a T1 and a T2 weighted image. So remember, on T1, white matter is brighter because it's more rich in fat. Fat is more prominent on T1. Fat is more prominent on T1. And T2, notice, the ventricles are brighter. Why? Because it has CSF. Okay, CSF. And of course, this white plane here is subarachnoid space, which also contains CSF. That's why it is brighter on T2. Okay, white matter, remember, what is on the surface of the cortex? It is gray matter. On the inner part is the white matter. So see, here there's a surface of gray, which is the gray matter, and of course, the darker area here is actually corresponding to the white matter. White matter. Okay? And of course, we also have flare sequences. Flare is basically, they suppress the fluid. So it's still a T2 image. As you can see, they're similar. White matter is darker and gray matter is more bright. But here, you do not have the signal of the CSF. You can see the subarachnoid space appears black, as well as the ventricular system, they appear black. So flare sequences are actually T2 weighted images, but they send radio frequencies to suppress the fluid signals of an MRI. So usually, if you want to better delineate the ventricular system, and of course, if you have other suspected pathologies that would involve removal of the CSF for better visualization, then flare sequences are helpful. So which scan best defines an abnormality? On T1 images, these are the following. So anatomical details, of course fat-containing structures, because they appear brighter on T1. And of course on T2 images, these are the abnormalities that you can see. So infarcts, chronic hemorrhage, they're more prominent on T2 weighted images. So there are also special techniques in MRI, such as diffusion weighted MRI is an example of endogenous contrast using the motion of protons to produce signal changes. What is a diffusion weighted MRI? It is obtained by applying pairs of opposing and balanced magnetic field gradients, but of differing durations and amplitudes. The primary application has been in brain imaging, mainly because of exquisite sensitivity to early detection of ischemic stroke. Okay, sometimes in our practice, we also use diffusion-weighted MRI for patients with suspected cholesteatoma that are not well defined on CT, or for follow-up post-operatively. If the patient has money, of course, we can request for a diffusion-weighted MRI to check post-cholesteatoma surgery. Okay, so normal motion of water within living tissues is random. In acute stroke, there's an alteration of this homeostasis and produces excess intracellular water or cytotoxic edema with an overall decreased rate of water diffusion. Of course, if there's already so much water intracellularly, there is decreased motion of water within the affected tissue, and therefore areas of cytotoxic edema in which the motion of water molecules is restricted, they appear brighter in diffusion-weighted images because of lesser signal losses. So diffusion-weighted MRI, DWI, DWMRI, useful for detecting early acute ischemic stroke. So of course, approaching an MRI, how do you read an MRI? So usually you have image delineation. Of course, you have to appreciate normal anatomy. Preferred scan is T1 for any pathology. Preferred scan is T2. Of course, you have the three different planes in which you view the MRI. So you have the axial plane, coronal, and sagittal. Of course, for the skull, you have to view the soft tissues. What are the soft tissues of the skull? So you have the scalp, temporal muscles. No? You have the diploic spaces of the skull bones. Of course, you also have to evaluate the ventricles, the cisterns, and the sulci. If the ventricles are enlarged, the patient could have hydrocephalus, or if it's a different shape, then it could be that the patient has a space-occupying lesion producing a mass effect. Space-occupying lesion could be anything. Hemorrhage could be a space-occupying lesion. Of course, symmetry, if they're not the same. Symmetry of intracranial contents. You have to note, of course, normal gray and white matter differentiation. You have to evaluate the deep nuclei. What are the deep nuclei? You have the lentiform, caudate nuclei, the brainstem, and the cerebellum. And of course, the blood vessels. For the blood vessels, you can have different sequences like magnetic resonance angiography or arteriography to evaluate better the circle of Willis. You can trace the anterior and posterior circulations of the brain, so you can actually look into the internal carotid artery. You can see the branches, middle cerebral. You can see the circle of Willis, anterior cerebral arteries, and of course, you can also have an MRV or magnetic resonance venography, where you can see the venous sinuses better. So you can evaluate the dural venous sinuses, superior, inferior sagittal sinuses, the transverse sinuses. Of course, focal abnormalities, any space-occupying lesion or signal intensity changes. So this is an example of axial cuts on an MRI. So you have foramen magnum, medulla, the pons, the midbrain, third ventricle, and so. Okay, so in this image, this is a cut through the base of the skull, level of the medulla, the nose. So you can see these are the maxillary sinuses. Okay, this is the nasopharynx. Nasopharynx. How do we know this is the nasopharynx? Because this is still so far down. Of course, if you do not have this image right here, on this image you can see that this is the nasopharynx because this is not the sphenoid sinus. But if you only have this image here, you can note this is still the nasal septum, so it's still so far down the nose. It's not yet at the level of the ethmoid sinus. And remember, the sphenoid sinus is way above, at a higher level, approximately at the level of the ethmoid posterior ethmoid sinuses, or even higher, or sometimes a bit lower. Okay. So at the level of the caudal medulla, still you can see maxillary sinuses, medulla, and the cerebellum, of course. All of these images are actually in Radiopedia, of course, and also in your book. Okay, we will not go through these images. And then, of course, you also have coronal sections. Okay, contrast agents. Sometimes you request for MRI and you request for contrast, right? Principle of contrast uptake are the same in CT and MRI. They enhance CNS pathology due to disruption of blood-brain barrier. Unlike contrast agents used in CT, which are directly visualized, those used in MR produce local alterations in the magnetic environment. That's why the most popular contrast used in MRI is gadolinium, which is a heavy metal, because it produces a disruption in the magnetic environment because it's metal that influences the MRI signal intensity. It is the effect of proton relaxation that appears on MRI and not the contrast itself. So it's not the contrast itself. Unlike in CT, where the contrast itself is visualized because of its different density compared to the surrounding structures. In MRI, it's actually changes produced by the contrast. So gadolinium is a paramagnetic agent responsible for T1 shortening of MR images, and shortening of T1 leads to a higher signal intensity, and hence areas of gadolinium accumulation appear bright on T1. So it also shortens T2, but the effect is less compared to T1. So these are the normal contrast enhancing structures of the brain on MRI. So normally the pituitary stalk. Why? Because the pituitary stalk partly is not part of the blood-brain barrier. You have the median eminence, dural sinuses, and cortical veins, and of course the choroid plexus, because that is where you find a lot of blood, because it's where the system comes from. Okay, advantages of MRI. What are the advantages of MRI over a CT scan? Number one, MRI produces better contrast and tissue discrimination. That is number one. If you want to see cancers, or if you want to see different types of hemorrhages, being able to differentiate pus from hemorrhage, from fluid accumulation or edema, MRI is your choice. So it has better contrast resolution of soft tissue. If you want to view soft tissue, if you want to view the brain, if you want to see if it's a meningioma, if it's intracerebral, or if it's slightly subarachnoid, sometimes these lines can blur in CT, but in MRI, they're better distinguished. Okay? Better soft tissue resolution. And of course, ionizing radiation is practically absent in MRI. CT, we all know, it uses X-rays, and it uses a series of X-rays, so it's higher ionizing radiation, higher effect on the patient, whereas MRI, of course, no short and long-term effects because it does not have ionizing radiation. It has many details even without an IV contrast. So this is what I was telling you. MRI, you can easily distinguish, even for us, we can easily distinguish if what is inside a sinus is blood, or is it pus, or is it more proteinic secretion, or a fungus ball. So all of this you can see with an MRI, but it is very difficult to do that with a CT scan. It can be used in patients with renal impairment. So as we all know, most of the contrast used in CT, they are iodinated contrast, and they are excreted through the urine. So once they build up, it's toxic because some patients can actually develop allergies. But in MRI, because it can be used in patients with renal impairment. And pregnancy, of course, is not a contraindication because there is no ionizing radiation. What are the caveats of MR imaging? Of course, it is very sensitive to body movements. So remember, protons have, of course, there's movement of protons during body movements, and one of the weaknesses of MRI is that because it takes a long time to form the images on a computer, is sensitive to body movements. It produces a lot of noise during examination, and it is time-taking, or it takes a long time for MRI to produce images of a patient. And so it's of course difficult to perform in claustrophobic patients, Sometimes it is less sensitive for detection of calcification. Why? Because calcification is better picked up by CT scan. And it is relatively insensitive to bony cortical abnormalities. So like I said, MRI, better for soft tissue. If you want to evaluate bone, you are better off with CT scan. Especially the bone though, the CT scan, because the CT scan will produce better bony detail. Better bony detail for CT scan. Okay? Thank you all for listening. We will have your evaluation exams Thursday. Please all study and good luck.